I'm Kathryn Zox, your social worker with a microphone, and you're listening to The Kathryn Zox Show. And joining me today is Dr. Tyler Evans. We're going to be talking about street medicine, the last mile to ending the HIV epidemic. The science already exists. PrEP is highly effective, and antiviral therapy can reduce HIV transmission to effectively zero. Yet in 2022, approximately 31,800 Americans acquired HIV, while millions remain disconnected from consistent care due to homelessness, incarceration, untreated mental illness, substance abuse disorders, stigma, and other structural barriers. Dr. Evans, who is CEO of the Wellness Equity Alliance, is a physician practicing street medicine, and he's helping lead efforts to end the HIV epidemic by focusing on individuals often left behind by modern healthcare systems. He discusses why addressing, and that's what we're going to do today, addressing the last mile of HIV care, which requiring meeting patients beyond just traditional clinical settings. He's held senior leadership roles in government and nonprofit organizations, including serving as New York City's first chief medical officer during the COVID-19 pandemic and leading infectious disease programs for the AIDS Healthcare Foundation. Welcome to the show, Dr. Evans. Nice to have you on this morning.
Thanks for having me.
Well, this is Pride Month, so I think this is like a really good topic, or a topic we need to address anyway.
Yep.
And I think one of the things that you've said is Pride. What's happened is that Pride Month conversations around HIV often miss the populations that are still excluded from care. So let's sort of dive in with that. We're not really addressing the problem. And I just read some of the statistics in the beginning, how many more people are diagnosed with AIDS because because there are barriers to their care. And one last thing, street medicine. You're a street medicine doctor. Can you get a degree in that? How does that work?
Not yet.
Yeah.
I think it might be coming. In fact, so our basically, I'll just sort of unpack what street medicine is.
Okay.
Street medicine sort of was founded by a sort of visionary physician, Jim Withers. He was one of our founding members of our board, and in the streets of Pittsburgh. And really, it was just about sort of the radical changes in the way that the patient-physician relationship was sort of set up, and kind of dissolving the sort of conventional four walls to a kind of medical exam visit, and just meeting folks where they're at. And so that movement has evolved significantly over the decades. And in California, the movement has really kind of swept the state. The vast majority of counties in California have at least one street medicine team, and there's a number of other states throughout the U.S. It's not just some radical fringe California experiment. There are many other states who have stood up street medicine programs, and in fact, there's an international movement on it. Now, the way that we are approaching it is different. We are approaching street medicine through what we describe as a syndemic sort of lens. And so specifically HIV is often framed, and we really promote this idea that HIV is not just a singular infection, it is a syndemic, meaning it's a term that was coined by Meryl Singer, and it essentially defines
How are you syndemic? Can you spell that?
oh yeah, Syndemic. And essentially it defines the way that diseases sort of interact with one another. There are sort of three different dimensions to the definition. And but in a nutshell, basically it's the way in which diseases or epidemics particularly sort of interact with one another, and ultimately synergistically amplify the outcome. So examples for HIV are hepatitis C. Somewhere between 30 to 50% of people are co-infected with hepatitis C. Now, many of those have at this point been treated or cured. Sexually transmitted infections or other examples. But But examples that are, I think, beyond the infectious disease nature are important to note here. I write a lot about this in my book, Pandemics, Poverty, and Politics, where we have to really address the social drivers, the social determinants, and the political drivers, increasingly more relevant in today's world, how those impact infectious diseases to go from sort of outbreaks to epidemics to scale to pandemics or public health emergencies of international concern. And HIV is a quintessential example of that. I write about that extensively. And so, the social drivers, especially poverty, is a sort of influencer or disease in and of itself. And when we sort of incorporate all the other social drivers, including systemic racism, stigma, um, mass incarceration, et cetera, that really impacts the way in which HIV has sort of scaled both in the United States and abroad. And so, and then there's many others. I mean, behavioral health is a big one. Behavioral health we define as both mental health and substance use disorders. On in a sort of more concrete level, kind of bring it down from the abstract. What that means is, as a doctor, I cannot really treat somebody who's infected with HIV or at risk of HIV. I cannot give that person a pill in the streets unless I am really addressing the sort of the context, the macro in which that person is sort of living. And so that's really what HIV street medicine to us is. It is basically combining the principles of innovative clinical service delivery models, new technologies and innovations in HIV treatment, including long-acting injectables. For example, there's a new medication out there for prevention. It's called lenacapavir. That's manufactured by Gilead. I have no stock in Gilead, and it's a long-acting injectable. It's twice a year, and it gets to nearly 100. It's nearly 100% effective in terms of prevention. So that's
So
pretty much.
what I'm just going to interrupt you for a minute,
Yeah.
because you are saying that the tools are there and you've defined what the problem is, which seems, as you're describing it, overwhelming. How are you going to get all of what these people, what the your patients need who are in the streets? How do you do that? How do you actually execute that? I mean, because of those barriers that you're talking about, getting to your patients.
Right.
Yeah.
So the HIV street medicine model is really just it's incorporating the sort of the components of HIV care delivery into the street medicine model. So essentially, it's bringing together two different systems, public health and health care, which often don't interact well with one another. And we thought that the COVID pandemic would sort of change that, but we've kind of gone several steps backwards. So what this does is really it's an opportunity, it's a catalyst really for system transformation between public health and healthcare. And operationally, what the model is you have a team. A lot of people think of this as mobile units. It's not exactly the same. There's a care continuum that includes mobile units, but street medicine is really operationally a team of somewhere between three to seven team members, including a medical provider. And that does not need to be a physician. Definitely does not need to be an infectious disease physician. My background is in adult infectious diseases and addiction medicine. But it could be an advanced practice provider, including a nurse practitioner, a physician assistant, as well as a nurse, ideally a registered nurse, but we have used models with medical assistants or LVNs or LPNs. But it's really heavily kind of focused on CHWs, community health workers, and or care managers in a place like California.
Okay. Does that
And then
include social workers?
I was about to say that. And then there are in the ideal models, we will include LCSWs or LMFTs as behavioral health therapists.
Okay, so you get the team, you get what kind of support do you get? What kind of support are you getting in California? You mentioned this model is being is not just in California, it's in other states as well. But I'm thinking of now, I mean, public health is a big issue now, not just related obviously to HIV, but it seems to me we have like really gone backwards in terms of how we're delivering public health vaccines, for instance. So how does that, yeah, how does this fit into the bigger political picture?
Right. Well, I mean, just to sort of identify the elephant in the room, I mean, the public health systems, both on a federal and sort of local level, have been, attacked, systematically attacked by the current administration. It's being radically and uh, sort of drastically dismantled and dissolved. And so, it's yes. So it's very in this sort of austere environment, it's very hard to build. Having said that, we really think, particularly HIV street medicine, is a I guess to zoom out here, HIV has always had bipartisan support. And In fact, I think there's been more support for HIV really from the right than there has been from the left. And when we look at internationally, PEPFAR, for example, the President's Emergency Plan for AIDS Relief, that was a signature legislation by President George W. Bush. So there's that. There is that bipartisan support. Also, HIV street medicine it's a sort of it's a local response, which really seems to have it's a local response to a systemic issue, and so that really seems to have traction from both sort of political camps, and it is a and it's also possible, and I can explain it. It's also possible to fund this through a public-private partnership, and that really has a lot of traction in today's political environments as well. But like I said, there are a lot of folks, a lot of systems spend a lot of time thinking about homelessness, and this is a solution to it. Unless you can't just, homelessness to solve, quote unquote, solve homeless. I'm using air quotes. You can't see me. You cannot, it's not just about creating beds or permanent supportive housing. That is an example that is part of the solution. But we strongly believe that, given all of the social drivers, given all of the health issues, and especially given the behavioral health issues, unless you address those, um, in a sort of transition plan to get those people back into supportive housing and include supportive housing, including housing specialists and the funding, obviously, to get there, then those people are going to be rapidly unhoused again. So the plan really needs to include sort of wraparound services, and that's really what we provide. I'll pause, but I can sort of provide examples of the funding sources.
Yeah, well, you're talking about, I guess, in social work terms, I'm a social worker,
Yeah.
the whole gestalt, that's what
Yeah.
you're saying. And you have to address all of that. Otherwise, you just get back to where you were. But what
Right.
about how many, I mean, you're talking about these teams. We'll take California. Well, how many teams do you have? How is it set up? I mean, and how
We
do you,
have,
yeah.
well, I mean, every group's going to have sort of a different definition of that. We have close to 12 teams in Southern California. So right now we're in 4 counties in Southern California. We're working with some other states as well. The state of Maine is asking for our assistance. We're also talking to a few other states. We've had some operations in New Mexico, et cetera.
Where does New York stand since I'm in New York, and since we're in New York?
Well, that's a good question. I'm from New York,
Oh,
and I was, as you had mentioned, I was the chief medical officer for New York City during the COVID pandemic. New York, when it comes to there are street medicine teams in New York, and there's actually more of an uptake in outside of New York City than there are in the city. When it comes to HIV street medicine, there really isn't anything at this point, but we are talking to the highest levels to see if there is any interest. And in fact, we're presenting to New York State AIDS Institute in a few months about the model to sort of try to get their blessing in terms of our guidance. But you asked an important question in the beginning. Can you get trained or licensed in street medicine? You definitely can get trained, and we are increasingly trying to incorporate into sort of the as a conventional part of sort of care delivery. We actually, some principals of my organization, Wellness Equity Alliance, we just wrote a few chapters in a book called the Fundamentals Textbook for the American Academy of HIV Medicine. So now that this is over 10,000 HIV providers across the country can get credentialed through this academy, and they have to study this book, and they're tested on these questions, and we are now writing these questions. So, so the plan is to basically try to get some states like New York, like California, to affirm or vet these best practice. I'm not going to call it guidelines, but these sort of best practices, increasingly with more data points to demonstrate that this actually works, that we could actually get to. We're calling it the last mile. The reason why it's calling it the last mile is because, and this is very important during Pride, because and I can't tell you how many times as an HIV doc, how many times people will often, like particularly the lay population, will say, "Hey, is that still a thing?" Yes, it is still a thing. Um, but we've had some incredible accomplishments in the HIV world, and that's been just through collective advocacy and scientific breakthroughs, and a lot of funding. But we're still not there. We're still not in terms of ending the HIV epidemic in the United States. We are still not there. And the CDC and other federal agencies have identified it's coined the EHE or the end the HIV epidemic. And there are structural sort of guidelines and goals there, and an important one um, that is. That is sort of taken from the UNAIDS goals, which is the 95, 95, 95, trying to get basically 95% of people living with HIV to know their status, meaning getting tested, 95% of those who are testing positive to get them on treatment, and 95% of those who are on treatment to get them virally suppressed. The
Well,
problem, the problem
aren't
is,
we talking about we're talking about I guess different stratas of society. I mean, I guess I'm asking you this obviously, like middle class people, upper middle class people, are they getting they're getting treatment, they're getting they have access to the medication, they have access to physicians, et cetera.
yes.
Are you
Yeah.
so you're talking about just a certain population, the ones,
Well,
yeah.
Well, I mean, these goals that I just talked about, that's for the entire population. Now, what happens is in our brick and mortar clinics, right? In our conventional clinics, you will get. I used to be medical director for this one clinic. We had over 2,000 HIV positive patients, and our viral load suppression. That means people that are treated, there is no detectable viral load, which is great because not only does that sort of stop the disease progression to some extent, it's a bit complicated. But it also reduces, not reduces, it completely eliminates the risk of transmission. There's actually a campaign called U equals U that was promoted several years ago, which means undetectable equals untransmittable. So from a transmission, from an infectious disease epidemic standpoint, if you get everybody virally suppressed, then you cannot spread the infection anymore, and the epidemic dies out. It's kind of the same principle as vaccinations. But the reality is the you just said the sort of middle to upper middle. I don't like the term class, but people with sort of privilege will ultimately they'll come into our clinics, and we can get viral load suppression rates of I I like the most socially complex. So my viral load suppression rates would probably be around 80 to 90%. But there are certain clinics where you can get up to 100% viral load suppression rate, right? Everybody's coming in and everybody's taking their meds. But there are many people that don't go to those clinics, right? And where are they? They're in the streets, and they're still spreading the infection, right? So until we get to the streets, that epidemic will continue to be sustained. And so we have to remember the forgotten. And I mean, there's so many impactful stories that I have where, folks had not been in care for years and we call them, it's a T cell or CD4 count. It's an example of it's a quantifier of your immunity, where they basically had almost no immunity left, and were really on their last leg. And we provided the care, and we got them back in the care and got them healthy and got them housed. So until we break down the model and really meet people in the streets, meet people where they're at with this innovative clinical service delivery model, we're never going to really be able to end the epidemic.
Well,
We
what
have.
about the impact globally? Now, I just saw this. It was a headline this morning. I didn't read the whole article in the New York Times that AIDS is on the rise in Africa. again?
Yeah, I mean
How does that impact us?
it is. I mean, we are. It's a great question. We're all connected, right?
Yep.
And so when it comes to the Ebola outbreak, I worked on two Ebola outbreaks in the past. When it comes to other infectious disease outbreaks, when it comes to measles, et cetera, I'm very concerned right now about the World Cup and sort of the infectious disease sort of risks there. We're all connected, and if we don't acknowledge that, we're completely missing the boat. There is microbes do not respect borders or boundaries, and they will impact it will impact us. And so, with the radical dismantling of our public health systems, including our global health systems. I mean, this is a big reason why the Ebola outbreak right now is scaling was because of the sort of the dismantling of USAID as well as other global public health sort of infrastructure. Us pulling out of the WHO, a World Health Organization, for example, was a terrible idea. The World Health Organization essentially acts as a mothership. It's a coordinating agency, and it only really works effectively if the nations are working together with it, the sort of respective CDCs or Centers for Disease Control.
Well,
And
you
the
were
moment,
always talking, you just mentioned, or that you mentioned earlier, that HIV has always been supported by not just the left, but the right, and maybe predominantly the right.
right.
So, what in this administration, or why is this different, and how do we, I guess, try to implement change? I mean, what kind of power do we have to do that?
I mean, this administration is unprecedented. It's there is no there. I mean, there's no right, there's no left. There's just it's just Project 2025. I mean, it's just destroy. And so they have just tried to destroy any sort of foreign aid, which is not only is it soft power, but it addresses such from a public health global health security standpoint. Unless unless we have those investments, excuse me, unless we have those investments for infrastructure, then we put Americans at risk. There's no doubt about that, and we are increasingly putting ourselves at risk as the result. PEPFAR, for example, like I was saying before, signature legislation from George W. Bush was one of the single greatest public health implementations in contemporary history, and we were doing great. We had great progress, great traction from an HIV standpoint. Now that much of that has been repealed, we're seeing the results. What you just said, that the numbers are going back up. The numbers are definitely going up in certain places in the U.S. as well. A lot of that is attributed to injecting drug use. HIV really, the paradigm shift sort of shifted from the 80s and beyond, where many of folks who were injecting drug users were the sort of were at the highest risk, and it sort of switched more to sexual risk. I mean, sexual risk was always there, but most people perceived it as sexual risk being the sort of the number one sort of influencer of transmission, and there was a lot of truth to that. Some of that has changed, where it's not the sex so much that's leading to risk, because a lot of people who are at high risk as a result of sex are on PrEP. And so it's really it's folks who are using drugs, particularly injecting drugs, are the most at risk. And we're seeing outbreaks in the South. We're seeing outbreaks right now in rural Maine, and in other places. So we really need to get these models to them, whether they're living in the streets or whether they're housing insecure. I often argue that at least half of America is one paycheck away from being housing insecure, and it's getting worse. So we really need to get the medications and the access to them before they are infected.
So much information for us to take in today, and I'd like to have you on the show. I actually like to have you on the show again also to talk about Ebola, and that, because that's happening right now here, and you just touched on that a little bit. But anyway, Dr. Tyler Evans, we have a couple minutes left, so to give us platforms to go to where we can get more information about what you and I have been talking about, and what you are doing,
Sure. So you
and your
can
book, 'cause you mentioned your book earlier.
Yeah, so you could check us out at wellnessequityalliance.com. I also have a website, tylerbevansmd.com. And then my books, the name is Pandemics, Poverty, and Politics. You can get it on Amazon, Barnes& and Noble, and it's published by Johns Hopkins University Press. You can read more about the concept of street medicine through the Street Medicine Institute, University of Southern California, where I'm also a professor at, and the concept of HIV street medicine increasingly will be presented at conferences. I'll be at the International Association of Providers of AIDS Care conference next week in Puerto Rico, and yeah, stay tuned.
We will stay tuned and we'll have you on again. Thank you so much. As I said,
Sounds
great
good.
information. Yeah. And
Yep.
we want more from you. Thank you.
Thank you.
I'm Kathryn Zox, your social worker with a microphone, and you're listening to The Kathryn Zox Show.
And joining me today is Janice Earlbaum, author of Girl Bomb. First published in 2006, Girl Bomb quickly received critical acclaim for its unflinching honesty and fast-paced storytelling, offering a rare female-centered perspective on youth homelessness, addiction, and the complex relationships shaped by friendship and first love. Janice Earlbaum's distinctive voice, wry, resilient, and unmistakably Gen X, helped establish the memoir as both a compelling coming-of-age story and a vivid cultural snapshot of its era. Now, this is nearly 20 years later. Girl Bomb remains strikingly relevant for its exploration of mental health, homelessness, and the experiences of LGBTQ plus youth. She's a former editor at Bust Magazine, and her work has appeared on MTV and has been featured in Harper's Bazaar and Vanity Fair. And her writing, Janice's writing, has also earned praise from the New York Times Book Review. Welcome to the show. Nice to have you on today.
Thank you so much. I'm really excited to be here.
I'm excited to have you. Now, okay, so Janice, we're talking about a book you published this memoir, 20 years ago, right?
20 years ago,
That's
yes.
long time. So what
Yes.
has changed in those 20 years, if anything?
Well, when I was part of the shelter system, which I was very briefly at the age of 15, I left home, my mother's home, due to some domestic violence issues with her fourth husband. So I was in the shelter system very briefly, New York City, 1980s. And then I went back around 2005 when I was writing Girl Bomb. I felt like it was important for me to revisit the building that had been sitting there in Midtown Manhattan. I lived two subway stops away and I had never been back. And also, since I was writing about the time, I really wanted to get it right. I really wanted to see what was happening now, 20 years after the events of the book. So, what I found was that not very much had changed at all, actually, and that the residents that I met in the 2000s could absolutely have been the children of the residents that I lived with in the 1980s. What I found was that structural inequality was firmly in place, as it always had been. That, as always, trans youth and gay, lesbian, queer youth made up a disproportionate number of the kids who were sheltered, and that there wasn't a really great line of communication between the residents who needed help and the people who worked there who genuinely wanted to help them. So, not much changed between the events of the book and me writing the book. In the past 20 years, I think there has been some beginning of a shift in perspective, but I don't think that the necessary shift has really fully happened yet. And we're still kind of operating in a 1980s way towards 2020's problems.
And why? Let's talk about why you think that's happened. I mean, I always think, in looking at it from a positive point of view, attitudes have changed.
Yes.
Have the Yes, let's talk about that. I mean, attitudes towards the LGBTQ community, and now hopefully trans people, trans kids.
Yeah.
Has it, or is this just my, wanting that to be that way? I guess.
No, no, we both want it to be that way, and I believe that that is so. However, the problem is that I think societally our values are shifting, but individually in the actual homes, in the families that these kids come from, there is still a very, very strong anti-gay, anti-trans sentiment. And it has always been that it is those kids who are forced to leave home. And that unfortunately hasn't changed, whereas society has begun its shift. It seems that in these individual kids' homes, the shift has not yet occurred.
Okay,
One
so
great
what's
thing,
happening? I was just going to
yeah.
say before you, what's happening or what's not happening in their homes? Are they coming from homes similar to the home you came from, let's say 20 years in
Yeah,
the
yeah.
80s? Yeah.
Yeah, many times it is what forces people to leave home is there's mental illness in the home, there's addiction in the home, there's domestic violence in the home. Absolutely, that most kids are still leaving home for exactly the same reasons that they did when I left home. It just wasn't safe anymore. The one thing that has changed for gay and trans kids specifically is that there are now shelters and group homes that specifically look out for gay and trans kids that didn't used to be there. One thing that hasn't changed is that there is very little governmental support for homeless youth. The largest provider of beds for homeless youth in the United States is an organization called Covenant House. And Covenant House is a faith-based organization, a Catholic organization that does fantastic work. They're all over the country and now they are all over the world. And all over the world, they are really on the front lines of housing homeless kids. But they were the only game in town, and because they were a faith-based organization, they did their absolute best. I must give them the most credit. They really did their absolute best to deal with the kids who were right in front of them. But now there are organizations like the Ali Forney Center and shelters like that, Sylvia's Place, that specifically understand what gay and trans homeless kids are going through. And so they have arisen to address more of that need. So I think that where the kids are coming from, that hasn't changed, broken families. But where the kids are going to, now they have a few more options.
So we have to, I guess there are two targets that have to be addressed. I mean, obviously, right? The broken families, the families who are struggling, and then the actual care for for the kids who wind up in foster care or wind up
Exactly.
in these shelters, I should say. Yeah.
Yeah, yeah. And foster care actually is the other place that they end up.
Yeah.
When I was there in the 1980s, I was under 18 and they kept me for over a month. They helped me get into a group home. These days, that's not true. If you're under 18, within, I believe, 72 hours, you're either home or you're in foster care. So, foster care is actually where a lot of people will wind up if they're under 18.
I'm finding there's not a lot of, I mean, obviously this show and many others and the work that you're doing, but there's not a lot of, you don't hear a lot about this. I mean, this is not a topic that that's on social media, for instance.
Yeah.
Or am I missing it? I mean, but it seems that it's not something that's really out there, that people aren't aware of what's happening, the conditions that you're describing.
Yeah, I would love to be able to harness social media in order to raise more awareness of the thousands, hundreds of thousands of kids who right now are, as I was, I call it halfway homeless, in that they aren't sleeping on streets. They have a roof over their head. They have some idea of where their next meal is coming from, but but that could change at any moment. They don't have any long-term sense of support or security. So technically, it's not people sleeping on the street, which is what people think when they hear the word homeless. But we're talking about hundreds of thousands of kids who don't have a reliable home to go to, a place where they feel safe, where they feel taken care of. And yeah, it's an enormous population. And the part of the population that gets seen is the addicted street kid who nobody really wants to help. Nobody looks at the kid with the dirty dreadlocks and the 19 tattoos and the very obvious drug addiction and the skinny pit bull. And they think, wow, I really, really want to go out of my way to make sure that that kid, who doesn't even look like a kid anymore, to make sure that that kid is okay. Those are the homeless kids that we see. We see the kids who have really shaken out at the very bottom of the barrel, who have absolutely nothing left. And a lot of halfway homeless kids don't fit that exact profile, but they're the ones who are out there sort of repping for the homeless kids. And they are very deeply in need as much as anybody else.
But those are the kids
Tattoos
we
and
see on the
addictions.
streets that we want to kind of
Yep.
avert our
Yep.
attention to. We don't want to see that because you were in a different position. And I do want to talk about your story because you were, what, 15 years old when you left an abusive home and you
Yes.
went into the sheltering system. But you had already been in high school, and I have this in front of me, starring in school
Yes.
musicals. And so you were in a different maybe position, situation, whatever, than the kids that we've just been talking about. And
Yes, yeah, I was. I was. I mean, most notably, I was white. And uh, I don't know why, but there were no other white kids there. I don't know whether they had never heard about Covenant House. I don't know whether other kids had wider support systems, if they had aunts and uncles that they went to, but certainly the other residents there were had not been raised with sort of the middle class assumptions that I had been raised under, that I would have safety, that I would have security, that one day I would go to college, all of these kind of taken for granted things that I had. Other kids that I was living with did not have. really, it was kids who came from the poorest populations, the most marginalized populations. So I don't know how it was that I found my way there and other kids didn't. Maybe I was more desperate than kids in my position usually were because I really didn't have friends or family members outside of my immediate family that I could turn to. But yes, I was in a very, very different situation. And I'm very grateful that I had that experience so early because I really did not understand what a bubble I had been raised in. I thought I had a very normal background. And then when I got to Covenant House and I met the people around me, I realized that I had come from a place of immense privilege that I had been blind to. And the privilege
So,
extended because I was white, I was seen as needing protection. So I got extra protection. I got extra attention. I was sent to a very nice group home in a convenient neighborhood. I was able to stay at the high school where I had already been attending, so there was no disruption there. So, yes, my situation was very, very different. As such, my treatment was very, very different. And I believe that that has changed today. When I was volunteering in the 2000s, I saw much more diversity of income, skin color, background, and I also saw people being treated much more fairly with standard. There weren't a lot of exceptions being made for people who might need quote unquote extra protection.
so that was very different. I'm picturing you. You were the only, I guess, as you're saying, you were like the only white kid. Did you have
Yep.
any? What about the support from the kids, not necessarily from the quote the administration or those who were taking care of you? How did you fit in?
Well,
Relationships with your
I
girl,
did not.
some of the girls.
Yeah, I did not fit in well because I didn't understand the culture that I was in now. I didn't fit in well. I had all these prejudices and all of this sort of ingrained racial nonsense in my head from society, from having parents who were somewhat racist. So I was coming in with all kinds of assumptions and attitudes that I didn't realize were hostile, that were offensive. So I did not rub everybody the right way. I'm very fortunate that
You weren't
some people
popular.
no, I was I was popular when it came to if I had food or money or cigarettes. All of a sudden, I was everybody's best friend. But
Uh-huh.
the rest of the time, I was not so favored. There were some residents who saw past my inability to fit in. They extended friendship to me, and I'm intensely grateful for those girls. And I wish that I had been able to be a better friend to some of the girls that I lived with because we all really could have used it.
Yeah. So let's fast forward a little bit today. So as a result of all of that experience, and people have to read the memoir and they'll get a more of a picture of what you went through. Where did that take you? Where has that taken you?
Where
That
has that taken
experience?
me?
Yeah.
Yeah, well, originally it took me into chaos. Going to a shelter, as I said, is a very short-term solution, and then going to a group home, and then going to another group home, and then moving back in with my mother, and then moving in with a boyfriend. And boy, there was a lot of bouncing around. Eventually, I got my own apartment at the age of 18, but even then, even having a secure place that was mine the internal instability that I had developed was really that was where I was operating from was just a tremendous need, a tremendous hunger, a tremendous sense of pain. So I stuck around having terrible relationships and being not a model citizen and doing many things that I regret until about the age of 25. And then I entered long-term talk therapy. And I really credit long-term talk therapy for changing my life, for changing me from the inside out, for really helping me to understand what was going on in my head. So it took me to some dark, dark places, even though I developed a cocaine addiction. I quit cocaine. Fantastic. I was homeless and then I wasn't homeless anymore. Great. Story's over. Wonderful. Everything's terrific. Except it really, really wasn't. It took many more years. I mean, I entered therapy at 25, but it took quite a long time before I was really able to understand that I carry my home with me, that I am home within myself, that I am not starving for something outside of me, that I'm not desperate anymore, that I have what I need. And now I am full, so full that I can give to others. So ultimately, it took me to a wonderful place, a place where I was able to go back to the shelter and hopefully to provide some value to other kids who were in the same position that I was in. I've been with my husband for 25 years. I have a wonderful, stable relationship. I have wonderful friends who are like a chosen family. So, my early experiences informed me in a way that I remain intensely grateful for all these years later. It scarred me. You know, uh, I can't be startled. If somebody startles me, I react very irrationally and can become violent. There are certain,
Almost like it sounds like the men and women who come back from a war have that reaction, that kind of a
yeah,
reaction.
yeah, there
Yeah.
is a little bit of that. And now I think that the issue of complex PTSD, this is a diagnosis that I've only really heard of in the past 5 years. That PTSD was a diagnosis for people who had gone through generally one really terrible thing, or a fixed period. They were at war for a year, and during that time, all of the events caused this trauma. What they're calling complex PTSD takes place over the course of 10 years, of 20 years, that kind of consistent trauma that comes from childhood abuse or neglect, that kind of consistent trauma that comes with a extensive episode of imprisonment or torture. And I think that that really is so. I think that the PTSD suffered by kids who grew up around violence is very different, very similar to that of people who went through regular standard issue PTSD. Yeah.
And Janice, because you talked about, and I just want to get back to this, the therapy and getting into long-term
Yes.
talk therapy, which many people are terrified to do. It appears as something risky, it's fearful.
Yes.
I didn't ask you exactly how long were you in therapy, and how was it to take that risk, to really dig deep, as you say, and go to those really dark places. Many
Oh
people
boy.
just don't want to do that
Yeah.
and don't. And
Yes.
it's so, I think, critical to the healing process as you described it. So how long were you in it, and how were you able to do it and sustain it? People get into therapy, then they leave because they get too scared. It's getting too
Yes.
close, right?
Yeah. Yeah. Well, if anybody is fortunate enough to have the resources and feel that they can take advantage of those resources. I mean, long-term talk therapy is not cheap. I was in therapy for 17 years with my first therapist. That's hundreds and hundreds of thousands of dollars of therapy. And I was very fortunate. I had a good job. I had health insurance, and I had some outside support that allowed me to get into it. And I got into it because I was very afraid that I was going to hurt myself. I really had come to a crossroads where it was like, are we going to live, or are we going to give up? And I decided that I wanted to live. And that is a very scary decision to make because then you really have to get your stuff together. So I entered therapy. It was very uncomfortable. It was very, very painful. And yet I could see the results almost immediately. It was like quitting smoking cigarettes. Oh, it was brutal. But every day I could feel as I was walking up the stairs in the subway that it got a little bit easier. Every time I sang along to the radio, my voice sounded a little bit better. And it was the same with therapy. It was painful. It was miserable. I was putting myself in psychological states that I had been running away from. I had done everything I could to avoid feeling these feelings, and here I was inviting them in and dwelling in them. It was awful, except my life kept getting better. I couldn't deny it. My life got better. It got easier. It got more understandable. And it wasn't a clear up trajectory. It went up, it went down, it went up, it went down. But over those 17 years, I found a adult inside of me who could take care of the kid who was still inside of me. And now we have a wonderful partnership.
It's a happy ending, if I can use the word happy. But
Absolutely.
I'm thinking as you're describing your um, journey, the commitment comes up. I mean, you got more and more committed, it sounds like, as you were going along, no matter how painful it was, but committed to the process.
Yes.
Yeah.
Yeah, I really was. And when it got painful and I felt like quitting, I thought, well, but then what?
Yeah.
Then what? I knew that I was on the path that was going to get me healthy, and it was the only way.
And you did it. We only have a couple minutes left, so we obviously want people to read the book. And the title of the book is Girl Bomb, and I've been talking to Janice Earlbaum, spelled differently.
Yes, but that is
Right?
where the name of the book came from.
Yes, bomb and bomb. Okay, great. And so give us websites to go to, platforms,
Okay,
other.
great. Well, I'm easily found at girlbomb, girlbomb.com. And in honor of the 20th anniversary of the book, I have put up a lot of behind the book photos and artifacts from that time. So once you have read the book, please go to the website and you can see pictures of some of the actual characters and stuff like that. So girlbomb.com is the best place to find me. I'm not a huge social media user, but I am on Instagram at Janice Earlbaum on Instagram. Um, and you can find me at janice.earlbaum@gmail.com because I love hearing from readers. And I'm always happy to hear from people who are in the same situation that I was in. So if that's you and you feel like reaching out, that's where you can find me.
Great. Thanks so much for being on the show today.
Thank you, Kathryn.
Yes, I really enjoyed hearing your story and sharing it. And yes, the memoir is Girl Bomb, and that's I should spell it GIRLBOMB. Thank you.
Thank you so much.
You're a social worker with a microphone, and you've been listening to The Kathryn Zox Show.